So having seen the depolarization, repolarization, as I told you, the purpose is to see whether all our segments of the heart is working properly or not. For that, you have to see each and every surface of the heart to see in that surface whether depolarization, repolarization is happening normally. For that only the lead systems have been developed to look at the various surfaces of the heart. That is the purpose of lead system. So as I know, to know and see whether all your surfaces in the heart are working properly. Second is to calculate axis. As I told you, the axis by which we know in which direction the cardiac vector is traveling. That's what the purpose of axis is. Then localized coronary heart disease, which of our, although we have two major coronary arteries, it behaves as a three vessel system. So which of these coronary arteries is diseased? For this also we know we must need lead systems. And know the position of the heart. Heart can be horizontal, heart can be vertical, heart can be intermediate. To know that, we have the lead systems. So this is once again a difficult topic because I'm going to spend considerable time on this topic because understanding this topic forms the basis of understanding coronary disease and axis. So without understanding lead systems, we cannot go ahead at all. So that's why it is also a little boring because once again purely physics. The lead system is purely physics. So that's why I request you to bear with me, and at the end of this lecture you will understand why we have spent so much time on this particular chapter. So luckily we have to learn only about 12 leads, luckily. So only 12 leads. There are 6 limb leads and 6 chest leads. These 6 limb leads are divided into 3 bipolar leads and 3 unipolar leads. I tell you what is the difference between bipolar and unipolar leads, but understand 12 leads, 6 chest leads, 3 limb leads. 3 limb leads are bipolar leads and 3 limb leads are unipolar leads. Whereas all your 6 chest leads are unipolar leads. So totally we have 9 unipolar leads and only 3 bipolar leads. So before we understand the lead system, we must understand what is the difference between an electrode and a lead. Electrode and lead are not synonymous. The electrode is a metal plate you are applying on the patient's skin to get the electricity from that area. That is an electrode. It is a physical object. Electrode is a physical object where you are applying on the patient's skin. Of course, with a little bit of jelly to eliminate the air interface between the skin and the electrode. So this is a metal plate you are putting on the chest wall and tying down on the legs and so on. The lead is an imaginary line. Lead is not a physical object. It is an imaginary line by which you are understanding my electrical activity is traveling in this way. That is a lead. So lead is an imaginary line. You imagine from this area to this area my electricity is traveling in lead 1, and lead 2 the electricity is traveling like this, and lead 3 it is traveling like this. So lead is an imaginary line through which you understand the electricity is traveling. As a student we used to wonder, the heart is in the chest. Why to tie down an electrode in the legs? Your organ is not in the leg. For no other organ you do that. You do not put a transducer to look at the liver in the leg and see the liver. Only for the heart. Heart is also here. You are tying down the electrode in the legs. What is the purpose? The remarkable property of the heart is the electricity produced by the heart, the sinus nodes electricity travels all over our body. The electricity travels through the body fluids and blood to the legs. So how to see the inferior surface? From the legs I look at the inferior surface. I cannot do laparotomy and see the inferior surface every day. So I have to look up from my legs, what's happening to my inferior surface. How to see my lateral surface? I look it from my hands. So that's why although your heart is in the center, you tie down the electrodes in the limbs because electricity travels all over our body. That is a remarkable property of the heart. No other organ does that. So that's why you can see that the ECG records the total electrical activity generated by the heart, and so the ECG curve remains multiple waves, and this electricity generated by the heart is carried to the surface all over directions, and that's why you tie down the electrodes on the heart. So as I told you, the lead is an imaginary line along which the electrical activity is being measured. It is not a physical principle. So now you understand what is difference between a bipolar lead and a unipolar lead. See, as you know, when we record a ECG from the ECG machine, it is a galvanometer. ECG machine is a galvanometer. To record something on the galvanometer, you have to tie something to the positive pole and you have to connect something to the negative pole. So both poles have to be connected. Then only the circuit is complete. You will record something. So that means in each one of these leads, of these 12 leads, you must know what is connected to the positive pole, what is connected to the negative pole. Although you are not going to do that while you are recording the ECG. It is not as if for lead 1 you are tying down on the left leg and right leg, on lead 2 you are changing the leads and so on. Your machine does all that. When you put this switch on lead 2, it switches over positive pole to this limb and negative pole to this limb. When you switch on to lead 3, it switches. But you must know, when you are recording lead 3, what you are recording. From which limb you are getting the positive signals and which limb you are getting the negative signals. For which you know the connections for each one of these leads, what is connected to the positive pole, what is connected to the negative pole. The simple difference between a bipolar lead and a unipolar lead is, bipolar lead look at two different limbs and see the difference between two limbs. For example, lead 1, I look at right upper limb and left upper limb and see in which of the direction my electricity is passing. Whereas a unipolar lead, I look at only one area of interest. For example, lead AVR, I am looking at only right upper limb. For lead AVF, I am looking at only the foot. What is happening to that particular lead, whether the impulse is coming towards foot or going away from my foot. Whereas lead 2, we are looking at potential difference between two arms. Whereas all unipolar leads, we record electricity only from that area. Only from that area. So that is the difference between bipolar lead and a unipolar lead. We have only 3 bipolar leads. Lead 1, lead 2, lead 3. That means these 3 leads, we are going to look at 2 limbs. We are looking at 2 limbs. So we must know for lead 2, which limb I am going to connect to the positive pole, which limb I am going to connect to the negative pole, in what direction in each one of these leads my electricity is passing. So look at lead 1 now. So lead 1, what I am going to do is connect the positive pole to the left upper limb and negative pole to the right upper limb. So right upper limb negative, left upper limb positive. So I am going to record an electricity which is going horizontally from right to left, isn't it? So the lead 1 is what lead? It is a horizontal lead because it is going to record an activity horizontally from right to left. So this is a bipolar lead. I connect to the positive pole, I connect to the negative pole. I know in what axis I am measuring the electricity. Whereas look at lead 2. Lead 2, positive pole I am connecting to the foot, left foot, and negative pole I am connecting to the right upper limb. So that means my right upper limb is here, left foot is here. I am connecting what direction now? I am recording the inferior vectors now. The impulses going down towards my left side, from right side to my left side. So the lead 2 records inferior vector which is directed towards left. So inferior and left vector is recorded by lead 2. So lead 2 is what lead? It's one of the inferior leads. It is not inferior to anybody. It records inferior surface. That's why it is one of the inferior lead. Lead 2 is recording inferior surface. So remember, left foot is positive, right upper limb is negative. Now look at lead 3. Here what I am doing is, once again I connect the positive pole to the left foot, but my negative pole to the left upper limb. Negative pole to the left upper limb. So now what I am recording is like this. From left side down and towards the right side. Lead 3 is recording once again inferior, but instead of left it is recording vectors coming towards right side, inferior and right. So lead 3 is recording inferior and right, lead 2 is recording inferior and left, L1 is recording right to left horizontal. So these are the 3 bipolar leads. So we have seen 2 inferior leads. So 2 leads which will give us an idea about the inferior surface, 1 lead which will give you an idea of my lateral surface. Now we go to the unipolar leads. As I told you, in unipolar leads, once again, so bipolar lead summary here. Lead 1, positive pole is left upper limb, negative pole is right upper limb, horizontal vector from right to left. Lead 2, left foot is positive, right upper limb is negative, so inferior right to left. Lead 3, left foot is positive, left upper limb is negative, so inferior towards the right side. From inferior and towards the right side is lead 3. So horizontal vector inferior and to the left and inferior and towards the right. So lead 1, lead 2 and lead 3. Now look at the unipolar leads. In the unipolar leads, we are going to look at only one surface or the only one area. For example, lead AVR means I am going to look at only right upper limb. Here once again I have to complete my circuit, isn't it? So each one of the leads I must know what is I am connecting. Bipolar leads it's easy because two limbs we are connecting, one to the positive pole, another to the negative pole. Whereas in bipolar lead I need only one lead. But at the same time I have to complete the circuit by connecting something to the negative pole. It's logical because I am going to look at the AVR, right upper limb I am going to connect to the positive pole. It's logical. But what I am going to connect to the negative pole, it is not the other limb. So what they developed is to connect to the left, to the negative pole, they developed what is known as central terminal. The central terminal is nothing but all the impulses or the electrodes coming from all the three limbs. For example, to record VR, we connect the positive pole to the right upper limb, we connect the electrodes from the right upper limb, left upper limb and left foot to the negative pole. So all the three limbs are called as central terminal. So in this way they completed the circuit. Positive pole to the limb of interest, all the three limbs to the negative pole. When they did that, the ECG complex was so small because although the ECG was recorded from the lower limb, by the time the electricity reaches the lower limb, it loses its amplitude. So by the time they recorded the limb leads, the ECG from the limb leads like this, connecting all the three limbs to the negative pole, the ECG complex were very small. So they wanted to augment the amplitude of the ECG complex. So they did the maneuver. What maneuver they did? They disconnected the limb of interest from the negative pole. For example, I am going to record lead AVR, my limb of interest is what? Right upper limb. So right upper limb I connected to the positive pole. Instead of connecting all the three limbs to the negative pole, I disconnect only the right upper limb lead from the negative pole. You understand what I am saying? The limb of interest is disconnected from the negative pole. In this way, the QRS complexes were augmented by 30%. That's why the small a stands in front of your A indicates an augmented VR. This augmentation is done by, so when you have VR only, all the three limbs connect to the negative pole. When you say AVR, you are disconnecting the right upper limb from the negative pole. So as you can see it here, positive pole is connected to the right upper limb, whereas the electrodes coming from the left upper limb and the left foot is connected to the negative pole. The right upper limb is disconnected from the negative pole. In this way, they recorded AVR. So AVR, see, in simple way, look at the lead systems as your cameras. The camera is looking at the various surfaces of the heart. My right-sided AVR camera is looking at my right superior surface. From the right superior surface, I am looking at my heart. That is my AVR camera. So AVR is looking at my right superior surface of the heart. So I know what is coming towards or going away from my right superior surface. So AVR gives you, so you must know how it is connected, what information it gives. AVR is connected, positive pole to the right upper limb. The electrodes from the left foot and the left upper limb is connected to the negative pole. The right upper limb is disconnected. You tell me how to record lead AVL, which will connect to the positive pole, AVL. Left upper limb. So which will connect to the negative pole? Right upper limb and left foot. Is so easy. So that's why you augment the electrodes, augment the ECG complex. So you can look at this. Now you have told me the positive pole is connected to the left upper limb. The right upper limb and the left foot electrodes are connected to the negative pole. The left upper limb lead is disconnected from the negative pole. So left upper limb, so having seen the connection, what is this camera is doing? AVL camera is looking at my superior left surface. It is the left and superior. So I am from the left and superior surface, I am looking through AVL. So lead AVF, you tell me how to connect. Positive pole is connected to the left foot. Negative pole is connected to the both upper limbs. Right upper limb and left upper limb is foot. Now AVF is dead vertical. When I looked at L2, it was inferior and left. L3 was inferior and right. AVF is dead vertical. Once again, this lead is recording inferior surface. So what are the three inferior leads? Lead 2, lead 3, you should not say like that. When I say inferior leads, you must say L2, AVF and L3. I tell you Y subsequently. So whenever I ask you what is inferior leads, you must tell me L2, AVF and L3. I tell you subsequently. So these are the three leads which are looking at the inferior surface of my heart. Whereas I have now two leads. L1 is looking at the lateral surface, AVL is looking at my high left lateral surface. So two leads are now looking at my high lateral surface. So I have developed now limb lead systems which can look at the inferior surface and high lateral surface. And one lead which is looking at my right superior surface is lead AVR. So lead AVF, left foot is to the positive pole, other upper limb leads to the negative pole. So this is your summary. So now I have developed 6 limb leads. Is that clear? 3 bipolar leads, 3 unipolar leads, how to augment the 3 unipolar leads and what surface I am looking at through this limb. The only one thing about lead AVR, the lead AVR is here, isn't it? Lead AVR is here looking at my right superior surface. My sinus node is here, my sinus node impulse is coming down, my ventricular depolarization is going towards my left ventricle. So my sinus node is depolarizing the atrium which is coming down. So it is going away or towards lead AVR? Away. So what will be my P wave in AVR? Inverted. So my QRS complex is going down and towards the inferior surface, isn't it? My depolarization, because my left ventricle is here. So this ventricular depolarization is going away or towards AVR. So what will be my QRS complex in AVR? Negative. If my QRS complex is negative, what will be my T wave in AVR? So AVR in a normal ECG will show all complexes negative. Your P wave is negative, QRS complex is negative, T wave is negative because atrial depolarization, ventricular depolarization are going away from AVR. In a ECG you find QRS complex upright in lead AVR, grossly abnormal depolarization. That means your depolarization is coming in the opposite direction, right? So don't diagnose myocardial infarction because lead AVR shows a Q wave, isn't it? Don't diagnose a myocardial infarction because AVR is negative. AVR should be negative in a normal ECG because all complexes are going. Now we come to the 6 chest leads. Once again, all these 6 chest leads are unipolar leads. That means they are going to give you the information only from that area. For example, I place lead V1, I am getting information only the area behind or below that lead V1, nothing else. So they are unipolar leads. Once again, the connection. First you must know the connection. V1 once again unipolar leads. The V1 means V1 I connect to the positive pole, simple. But once again the negative pole is central terminal. Central terminal is the leads coming from all the 3 leads. Here I am placing the electrodes directly over the heart. I am not placing the electrodes well away from the heart like lead 1 or AVF or like this. I am placing on the heart. That means my QRS complexes will be very nice and have a good amplitude. So here I need not do augmentation. So for this, all the 6 limb leads, I do not disconnect anything from the negative pole. I leave all the 3 terminals to the negative pole as it is. Connect either V1 or V2, whatever the area of interest, to the positive pole. So this is your connection. The important thing is you have to place the chest leads correctly. Correct interpretation of ECG, the main prerequisite is correct recording of an ECG. Without you are given a wrongly recorded ECG, all your interpretation will be wrong. So make sure your ECG technicians and nurses record ECG correctly, placing the electrodes correctly, for which the chest lead placement is very, very important. So please concentrate where to place all these electrodes. V1 is placed on the 4th right intercostal space close to the sternum. 4th right intercostal space is V1. V2 is on the 4th left intercostal space close to the sternum. So V1 and V2 is on the 4th space. You recognize 4th space from the Lewis angle, which is the 2nd space, 3rd space and the 4th space. Then we will not tell you anything about V3 now. We go to straight away to V4. V4 is placed in the 5th left intercostal space in the mid clavicular line. V5 is placed on the mid clavicular line in the 5th space. So V1 and V2 in the 4th space, V4 is in the 5th space mid clavicular line. V3 is placed between V2 and V4. V3 is placed between V2 and V4. V3 does not have a specific place. It is placed between V2 and V4. For example, you are the first thing you are going to do after this ECG workshop is what? Buying an ECG machine, right? So you're going to buy an ECG machine immediately after this workshop. You need an ECG technician to record an ECG, isn't it? Then you have to conduct the interview for the ECG technician. So what question you will ask for an ECG technician? Ask him to place V3. If the fellow goes and places V3 directly, he does not know anything about ECG recording. He must first place V2 in the fourth space, then he must place V4 in the fifth space, then put the V3 in between V2 and V4, then only he knows how to record an ECG. So this is where correctly recording ECG. Tomorrow go to the ECG room and see how our ECG technicians are recording. They are previously pasting posters in the walls. So they will have a brush which will paste this electrode place from V1 to V6 and place electrodes. This is a wrong way of doing the ECG recording. Each one of these leads have got a small paste confined to the electrode only. One electrode jelly should not mix with the next electrode jelly. The small amount of paste only for that electrode. If the jelly mixes with the other electrode, there is an electric short circuiting, your QRS amplitude will come down. So all these things matters in the ECG recording. So this is your V3. Of course, then the V5 is recorded once again in the fifth left intercostal space in the anterior axillary line, and V6 is on the fifth place in the mid axillary line. So V4, V5 and V6 in the fifth space, V1 and V2 in the fourth space, V3 is between V2 and V4. So mid clavicular line, anterior axillary line and the mid axillary line are the 6 electrodes placed on the chest. So as you can see nicely here, the V1 and V2, V3, V4, V5 and V6. So this is where how you place your electrodes. Now you also see how these chest electrodes are going to give us the information, right? V1 is placed where? Which ventricle? Right ventricle. So V1 is placed directly on the right ventricle. So what information V1 is going to give us? On the right ventricle. V2, V3 and V4 are placed on the interventricular septum and the antler wall. So V2, V3, V4, we are going to see the septum and antler wall. V5, V6 is my anterolateral wall. So it is placed on the sides. So I am looking at the anterolateral wall. So chest leads have given me an idea about the right ventricle, interventricular septum and antler wall and anterolateral wall. Through L2, AVF and L3, I saw the inferior surface. L1 and AVL have given me high lateral surface. So I have looked at all the surfaces now. High lateral surface, anterolateral surface, anterior surface, right ventricle and inferior surface. That is the purpose of your lead system. So all the systems are now, yes, you can see that now. So you can see that in some special situation like in pediatrics or in patients with the inferior wall infarction, to diagnose a right ventricular infarction, you have to place the right sided leads, or when you are suspecting a dextrocardia. In all these situations, you have to take the right-sided leads. Pediatrics, inferior wall infarction, right ventricular infarction and dextrocardia. These are situations you have to place the same area on the right side with 3R and V4R. Now, you can see that now L1 and AVL has given me the high lateral surface of the heart. Now you see my lead 2 is here, isn't it? Lead 2 is inferior and to the left. My AVF is dead vertical. My inferior, the L3 is inferior and towards the right, isn't it? Inferior and towards the right. That's why when I say the inferior leads, I have asked you to say it is L2, AVF and L3, because from the inferior and left, you are coming vertical and going to the right. Rather than you are saying L2, L3, AVF. When you say L2, L3, AVF, I know you do not understand. You did not understand inferior leads. When you say L2, AVF and L3, I know you know the position of the leads. From inferior left, vertical and inferior right. So this is your inferior surface, and as I told you, right superior surface is AVR, all complexes are going to be negative. You can see that my impulse is going away, my atrial depolarization is going away, my ventricular depolarization is going away. Most often this depolarization will come towards L2 because my left ventricular apex is here. So on a normal axis, my axis is likely to be going towards my L2 area. So that means it is going away from my AVR. So that's why AVR, all complexes will be negative. Whereas when you look at the chest leads, V1 is on the right ventricle, V2, V3, V4 in the septum and antler wall, V5, V6 gives me anterolateral surface of the heart. So look at the surfaces, L1 AVL high lateral, L2 AVF, L3 inferior surface, V1 is right ventricle, V2, V3, V4 interventricular septum, V5, V6 anterolateral wall. Which surface we did not see? Posterior surface, isn't it? Posterior surface is the one. We have seen lateral surface, we have seen the right surface, inferior surface, but posterior surface we cannot see because of very thick bones, very thick muscle. So from the posterior leads, you may not be able to record nice ECG from the heart. That's why majority of these posterior changes are inferred by the opposite changes happening on the anterior chest leads. Anterior chest leads are V1 and V2. For example, my posterior ST elevation is shown as an anterior ST depression. My posterior Q wave is shown as an anterior R wave. So whatever happening opposite on the anterior surface, I infer this is happening in the posterior surface. And there are certain special methods like a esophageal lead with which you can record the posterior surface directly, but it is not usually done. So usually we infer the posterior surface changes by looking at the opposite changes happening in the anterior surface. Is that clear? Now we have 12 leads. 12 leads have given an idea about the various surfaces of the heart. Now what we are going to do is translate into coronary artery perfusion territories. So next purpose I told you, what is the purpose of a lead system? To diagnose which coronary artery is diseased. So three coronary arteries, RCA, right coronary artery, left antedescending artery and left circumflex artery. Now we can see that. Now when you look at this inferior leads, L2, AVF and L3, it is right coronary artery. It is a right coronary artery which supplies the inferior surface of the heart. So whenever I have changes in inferior leads, ST elevation, ST depression, T wave inversion, I know which coronary artery is blocked. Right coronary is blocked. So whenever there are changes in inferior leads, I know it's a right coronary disease. Right? So whenever my right ventricle, V1 is on my right ventricle. So the right coronary supplies my right ventricle. So changes in V1 will tell me once again it is a proximal right coronary which is involved. It is a proximal right coronary because the first branch of right coronary is right ventricular branch. So if my right ventricle is infarcted in an inferior wall infarction, without doing a coronary angiogram, I know it is a proximal right coronary disease. The RCA is blocked beyond proximal to the right ventricular branch. V2, V3, V4, the septum and antral wall are supplied by the left antedescending artery. So most crucial artery because it supplies the main portion of the left ventricular chamber. So that's why LAD territory is very, very significant. And my lateral surface V5, V6 and my high lateral surface of L1 and AVL are supplied by the circumflex artery through the diagonal branches. So entire my lateral surface, L1 AVL is high lateral, V5, V6 is anterolateral, supplied by the right left circumflex artery. Inferior is supplied by the right coronary artery, V1 by the proximal right coronary artery, V2, V3, V4 is left antedescending artery. So by this, with the 12 leads, I have not only seen the various surfaces of the heart, whether they are depolarizing and repolarizing normally. If there are any ischemic changes or injury changes in these groups of leads, I understand this particular artery is likely to be obstructed. So now I have understood the surface, I have understood the coronary artery perfusion through the 12 leads. So L1 AVL is circumflex, L2 AVF L3 is right coronary artery, V1 is proximal right coronary artery, V2, V3, V4 is left antedescending artery, V5, V6 is circumflex artery. So now we have seen both the important purposes of lead systems. We have looked at the surfaces, we have looked at the coronary artery territories. Now this diagram I wanted to remember once again. Frequently we will be showing this diagram. What I have done is I put the heart here and put the electrodes, and I am going to name each one of these electrode by specific name. You tell me now, my L1 is what lead? What lead, what direction it was recording? Horizontal. So lead 1 is horizontal lead. Is that clear? It's a horizontal lead. Lead AVF is what lead? Vertical lead. So lead AVF is vertical lead. Lead 2 is between an horizontal lead and a vertical lead. So what lead it is? It is a intermediate lead between a horizontal lead and a vertical lead. So lead 2 is an intermediate lead. L3 is what lead? It is directing inferior and right. So what lead L3 is? Right. L3 is right because it is going to record my inferior and rightward vector. Remember, from the left upper limb towards the left foot. So it was directing towards the right side. So lead 3 is right. AVL is what lead? Very difficult question. AVL is what lead? Very difficult question. AVL is what lead? Left. AVL is left. It's a very, very easy question. So left, AVL is left. AVR is no man's land because everything is going to go away from the lead AVR. So now what I have done is that the 6 limb leads are, I have given a individual name. L1 is horizontal, L2 is intermediate, AVF is vertical, L3 is right, AVL is left, and AVR is no man's land where everything is going to go away from the lead AVR. Because as you know, from here, the atrial depolarization and the ventricular depolarization and the repolarization is going to go away from lead AVR. So not only I have understood the surface, I have understood the coronary artery perfusion, now I have understood each one of the leads in relation to the various surfaces of my heart. Is that clear? So you have to remember this. It's very important, this diagram, to understand the axis subsequently. L1, L2, L3, AVF, all the 6 leads. Now, tomorrow are you going to look at the ECGs? From tomorrow, are you going to look at the ECGs or not? Definitely. So from tomorrow, how are you